Hello, everyone. Welcome to ASFI webinar PGT-A Part 1. My name is Dr. Atsushi Tanaka. I'm the director of St. Martha Hospital and a professor at Adjunct University in Japan, and I'm the moderator of this session. Today, we have two presenters, but unfortunately, due to the hurricane hit the country, America, where Dr. Santiago Munné is living. So he can't participate in this session. But if he is available, he will join us halfway. Professor Santiago Munné from Spain, he is a professor at Yale University and the founder of many pioneer, many reference laboratories and companies. He's known by everyone as a pioneer of PGD and he has been contributing greatly to the advance of PGD. Professor Yanwen Xu is a professor at Yanwen University in China. Recently, ICMART reported that the total number of ALT cycles in China was 900,000. It's the largest number in the world. Amazing. I would like to start by introduction, a brief summary of the contents of the two presenters before entering the discussion. Dr. Munné points out the limitations of the current PGT-A in terms of inconsistency of doctoral skill and variously different art circumstances in each center. So he recommends metabolomics and automated art procedures. Dr. Xu addressed her opinion about current PGT-A from a clinical point of view. She insists that PGT-A is beneficial to patients suffering from repeated miscarriages due to advanced age when it is performed with highly qualified skill. She also points out that this ALT has not yet been established and many challenges still remain. So now let's move to the session. First is a slide. I will show you the three cases. So our first case is we are talking with Professor Shi. Okay, case one is that the patient is 40 years. She has had repeated miscarriages and performed PGT-A for 4 frozen blood cysts. 3 were trisomy or monosomy, aneuploidy. The remaining one was 80% mosaicism. What is our advice? Professor Shi, how do you feel? How do you do in this case?
It's a tough case, right?
Yeah.
40 years old and they had the history of repeated miscarriage and only got 4 frozen blastocysts and the 3 were abnormal, aneuploidy, obviously, and remaining one was a mosaic embryo with very high percentage of mosaicism. And I think it depends on which chromosome mosaic involved. If X chromosome, chromosome 21 and be risky. You need to talk with the patients profoundly and bring the possible damage, possible risk. In my center, the highest percentage of mosaicism we transferred is 70%. The patient got a normal pregnancy. Even the placenta, we checked the multiple tissues in placenta were all normal. So in this case, if it's not involved X chromosome and 21, chromosome 21, I may give my recommendation that she can transfer this embryo, but she must have the prenatal diagnosis.
Good. Thank you very much, Professor Shi. I complete agree with you. So if I were in a position, I will answer the same answer.
Thank you.
So now, looking at current condition in the world, their tendency to try to move to transfer the mosaic embryos, even if they have a very high grade mosaicism. Because it's very strange. Until now, there has been no report of abnormal babies following transfer of them high-grade mosaic embryo transfer. But I think further investigation with H-ray consortium or other big organization collect data, and so will give us a final answer. Anyway, now we both of you are agreed to transfer this case, this RAS only one mosaic, right?
Yes.
Okay, thank you very much. Okay, from case 2 and case 3, so everybody watching this webinar, so join us, okay? And push a button for poll. When a 43-year-old patient with a repeated unsuccessful arch asks you, which is preferable? First, we say donation, if your country is okay. Second is PGT-A. Which would you recommend? Push a button.
It depends on her ovarian reserve, the AMH level, and how many eggs she got in the previous cycles. If she still has a good ovarian reserve, she has the chance to get more than 4 or 5 oocytes. She may ask the help of PGT-A. It's my recommendation, PGT-A.
Yes, yes, because I think one reason is in China, also donation is not allowed, right?
Yes, it's
So,
allowed.
okay. Now its answer is coming. So answer was almost 50, like American presidential, 47, 85, 50, 80%, half even. Maybe I think it's very controversial. Anyway, my personal opinion in Japan, offshore also donation is not allowed. So many patients moving to Taiwan to receive the also donation. So maybe I think both of depending on the patient will. So I think it's a very agreeable answer. Thank you very much. Okay, move to the next slide, please. Next is K3. Who should take the responsibility when the wrongly diagnosed embryo is transferred? Oh, it's a very naive question. The doctor or the reference laboratory?
In our country, doctors facing the patients, all the explanation first explained by the doctors. And if the misdiagnosis happened in my center, we will recheck all the procedures, including the whole genome amplification products. And we will, how to say it? It's not the responsibility. The first important thing. The first important thing is find out why the misdiagnosis happened. That's good for the lab. That's good for the doctor.
Okay, thank you very much, Professor Shi. But answer was contrary to your answer. So about 70% of participants chose the reference laboratory should take a responsibility.
But
So in Japan, so not government, but the JSRM, Japanese Society of Reproductive Medicine, is a center. And this organization choose the certificated hospital can do that. So it means the selected doctor should be know everything about PGT-A. So because we receive all data, document everything from the laboratory. So we have to give the patient a final answer. And also we have to give the advice. If you're not so confident, why don't you do the prenatal diagnosis or something? So including everything in Japan, doctor should have taken responsibility. So we're very nervous, worrying about the case. So in such a case, we asked the laboratory, and because they know well much more than we, asking, is it okay? So don't you have a misdiagnosis and so on? And we put final answer. So maybe I think it's this point is controversial and very different depending on each countries. Okay, thank you very much. Okay, from now on, I move to the questions from the participants. So I like ask. So at first, to Professor Shi, do you think PGT have benefits for AMA, advanced maternal age patients who has lower 3 bile blood cyst?
lower number of lower quality or lower number of blastocysts. Sorry,
Yeah.
you mean the lower number and the lower quality of blastocysts?
No, viable blood cyst.
Viable.
Viable, it means quality is good.
Okay, your question means the PGT-A may reduce the viability of blastocysts, the damage to the blastocysts.
No. I think this questioner asking the advanced age, maternal age.
Advanced maternal age.
It's a risk for decrease the quality of the blood cyst. But this patient has 3 viable blood cysts. So PGT is have benefits.
Okay. Okay. For a patient with advanced maternal age and she has a good blastocyst, more than 3 blastocysts, will the PGT-A benefit her? I think
Yes.
it depends on her age, how old is she, and the second is depends on the consumption caused by the PGT-A.
Yeah, that's right.
And on the biopsy skill depends on the control awareness stimulation, amplification, and all these things cause our consumption. So if the annual rate is very high in her age, for example, 70% annual rate, if we pick up one embryo without diagnosis, then the chance of the annual will be more than 70%. So if the consumption is lower, we can minimize the consumption. Then she may benefit from the PGT-A. Because if we pick up one embryo blindly, the annual rate will be more than 70%.
Okay, thank you, Professor Shi. Okay, my answer is it depends on the patient well. So as you know, PGT-A costs a lot. And I don't know the exact how old she is, but maybe over 40. So 70% of embryo chromosome are aneuploidy. So success rate is 3, maybe all of them are aneuploidy. Or even if they not so rich, can afford to do repeated PGT-A. One thing, if the patient doesn't seem so serious to do the D&C after the miscarriage, again, one alternative way to repeat without PGT-A, because small chances by the 20 or 30% of embryo transfer are successful. So I always ask her husband together. So theoretically, PGT-A should be done, but success rate is very low in your for your age. So it is okay to can afford to do repeat, maybe twice or third time of PGT are necessary. So please conscious about it. And some patient choose PGT-A, and the other patient, no, I can't afford to do that. So I will do the same embryo transfer. Okay, please, 2 or 3. In Japan, maximum number is 2, but in such case, I transfer, I'm sorry, it's a secret, I transfer 3 embryos in such a patient. And resulting in the miserable miscarriages, but the patient never regret that. So this is a very controversial point. Okay, next please. Okay, Professor C, do 20% of testis embryo are damaged by biopsy? What do you think is the main cause of such a high damage to embryo rate? Could you tell the actual procedures of embryo biopsy in your country?
So actually, the consumption rate should be calculated depending on each center. So you need to got your own data using the morphology group as the control group and your biopsy group as the study group to compare to calculate the consumption rate. I will explain later in my lecture. And in my country, we did the blastocyst biopsy in recent years, and we compared the implantation rate between the blastocyst biopsy and the cleavage stage biopsy. Of course, it's a retrospective data, and the data show that blastocyst biopsy has a higher implantation rate compared with the cleavage stage. So I think the damage caused by the blastocyst biopsy is lesser than the cleavage stage biopsy. And I think the blastocyst biopsy requires skills. And for example, which stage you biopsy the embryos, is early blastocyst stage or late blastocyst stage, you did the acid hatching earlier or later, and all this will affect the viability of the blastocyst. And also the laser you use or mechanical method you use, and all may bring different damage to the blastocyst. And also the time, the interval between the biopsy and the vitrification may bring some damage, may bring some risk factor to the viability of the blastocyst.
Thank you, Professor C. So I understand very well. So when we started the embryo biopsy, the technique for the embryo biopsy is very hot topic, because how to do the technique is many types. So now it's a very safest way is at first, at the process stage, make a small hole, okay? Not using laser, with a manually. It might be just a little difficult. Or if just after the thawing, pick up the frozen liquid nitrogen. So at the time, the embryo is still shrink. So before they return to the normal, they cut, slice the space, zona pellucida. It's very easy. And wait 3 or 4 hours after the cutting the zona pellucida, the trophectoderm will spontaneously appear outside. So very easy to put it off of the trophectoderm. I think this is a very good thing. Okay, thank you very much. Okay, next please. Okay, it's okay. I will. It's very surprising that aneuploidy rates are so different among centers. Are there any kind of center certification to be able to select only to properly qualified ones? How different aneuploidy rates in different centers will affect result? So, Professor Xu, how do you feel about this question? Okay. Okay, I will answer for the participants. So I'm honestly, I am very surprised to hear this news in Japan. So JSRM, the organization, so certificate the center, not only the center, but also the doctor, hospital. So there is no big differences among them. So we haven't experienced such big differences between among the centers. So I would like ask Professor Shi, in your country, so you told in the slide that the government or local government will give a license to the hospital. So could you please explain about that?
It's a ART is a controlled service, and we can only do this PGT program after we got the permission from the government, and it's we can also call it license. It's all controlled. If the center had no license from the government, the center cannot do the PGT.
So everybody, if he is a obstetric gynecologist, can do PGT-A?
No, no.
What a...
Only the licensed reproductive center.
I see, I see. So this reproductive center is not so governmental or local governmental. It's private.
Some private center may apply for the license.
Okay, thank you. Okay, now I received a question. What is a recommended time between biopsy and vitrification? Can you answer, Professor Shi?
Oh, it's a tough question. We have done mouse embryo experiment, and we just want to check out the time interval, the best time interval between the biopsy and vitrification, and we divided several time intervals. However, the results is negative, and it looks like that no deep impact of the time interval between the biopsy and vitrification, in at least in the mouse embryos.
I see.
Now in our centers, we will vitrify the blastocyst within 1 hour after biopsy, just before the blastocyst expanded again, just before it.
So about 1 hour between the time lapse, okay.
Yeah.
And also it's a close question is what stage, if the blastocyst stage is early stage, so 1AA or 2AA, do you wait this early stage process to mature 4AA, 3AA, or do you do the process embryo
Until
biopsy?
stage 3, we
Mhm.
until
Wait,
7.
okay. So your answer is wait until 3AA, mature stage.
Yes.
But in terms of the technique of the embryo biopsy, so 1AA, 2AA is a little, I think it's easier to cut the procedure. It's not so expanded. So maybe I think it's both are equal. Okay, thank you very much, Professor C. Oh, next question. Dear Professor C, I have a question regarding the embryo transfer. Any chances of chromosomal disorder or probability of autism disorder can occur during the embryo transfer?
Any chances of chromosome disorder or probability of autism can occur?
Do you think it's a relationship between the autism and
I understand the question well. There's
maybe?
no, to my knowledge, the gene background related to autism disorder is unclear. Many children with autism cannot be found with the gene mutations now. So it's difficult.
Okay, I agree with you. So maybe one opinion is that this autism is might be closely related to the ICSI. So looking at the group of the ICSI analysis, so a little percentage of autism is increased, but not significantly. But I found that some papers about that, the relationship with the autism and ICSI, not embryo biopsy or freezing.
And also the folic acid supplementation may be related with the autism.
Okay, I agree. Okay, next, please. Okay, do you think the reference laboratory needs to be qualified as well as the hospital? If so, how do you think is the best way to select them? Okay, okay, I'll repeat. Do you think the reference laboratory needs to be qualified as well as the hospital? If so, how do you think is the best way to select them? It means by government or local government or China Society of Reproductive Medicine or private.
It's a tough question, right? Currently in my center, we did all the tests by ourselves. I know the situation in China. There are several great reference laboratories, and it's difficult to do the evaluation for them. But you can look at your own data after they send you back the results. And you can calculate the mosaicism rate, to calculate the embryos with inconclusive diagnosis, and calculate diagnosis whether it's correspondent to the theoretically ratios. For example, the affected embryos, the homozygous, heterozygous rates, and all this you can calculate it. And also you can get the results from the prenatal diagnosis. And it depends on the service this reference laboratory can give to you.
Okay, thank you. Okay, next we receive the question, which day would you think will cause more damage to the embryo during a haul at day 3 or day 5?
Oh, we opened the hole on the morning of day 5 or day 6, depends on the blastocyst development. We didn't open the hole on the day 3 because it's difficult to predict whether the hole is on the ICM size.
Okay, I agree with you. But I think during on the day 3 is a little beneficial effect because it's a very easier than day 5. Day 3 is much easier to make a hole because the pesida is thinner than day 5. But advantage is nobody know where is the industrial mass location. So if the hole is just above the industrial mass, it's difficult to embryo biopsy. So maybe I think it's probable, preferable to choose day 5 during.
Yes, I agree with you.
Okay. You report in your slides that PGT-A significantly reduced miscarriage rate and increased ongoing pregnancy rate, and the number of live births per transfer, but there were no differences in the cumulative live birth rate between PGT group and non-PGT group. Could you explain a bit more about this result? Do you remember your slide?
Yes, yes. And I think it depends on the nature of PGT-A. The nature of PGT-A is a selection. It means we selected the most viable blastocysts among a cohort of blastocysts. And if we have the chance to transfer all the embryos sequentially, then we got the same live births from this cohort of blastocysts. So it means that cumulative live birth rate should be the same, whether you do the PGT-A or not do the PGT-A. Doing PGT-A means that you select the most viable blastocysts first. So you reduce the time interval between the selection and live births. But if you do not do the PGT-A, then you have the time to transfer all the embryos sequentially. And you got the same live births.
I got it. I got it. Yes, I can understand what you mean, but advantage of your opinion is this patient has to do the many trial of OSA pickup, right?
Not many. It depends on the patient's will, right?
Okay. Anyway, the patient is older, advanced age, so she has to many times to get pregnant and result in the ongoing pregnancy because the miscarriage rate is higher significantly than the PGT-A group.
Yes.
Okay, so if the patient unfortunately can afford to do the PGT-A financially and don't feel so serious for the repeated miscarriage, this is one way. Okay,
Yeah.
I got it. Okay.
She suffered from the repeated miscarriage risk.
Question is, aim of PGT-A is to improve live birth rate in IVF. In advanced maternal age, aneuploidy leads to recurrent implantation failure and PGT cells lower. It's right. Live birth rate after IVF. So the ultimate solution is organ donation rather than PGT-A.
No.
So you answer the same question, please.
I don't agree with this.
Yes, but I think I like answer to this participant because this she must have been suffering from the many times of miscarriages and had a very severe experiences. So in such a case, I recommend also donation. So I think this is an alternative way to solve this problem for the patient because she has enough time for the second life starting.
Mhm.
So always this problem controversial was last. Okay. Okay. Next question: If you have an embryo with 30% segmental gain mosaic chromosome 13 and another embryo with 13% whole chromosomal mosaic chromosome 1, which would you transfer first?
Uh,
First one is 30% segmental gain mosaic
uh-huh.
at chromosome 13.
Mhm.
And second, next is 30% whole chromosomal mosaic at chromosome 1. Which do you prefer?
Mhm. All 30%. All 30% means it may be the artifact due to biopsy, due to amplification first. And secondly, there's one topic during during Asia this year, showing us that better prognosis of segmental mosaicism than the whole chromosome mosaicism. So based on this topic with very large numbers of mosaic embryo transfer, I may select 30% segmental gain at chromosome 13.
Okay.
But
Okay.
in my opinion, both embryos can be transferred.
Yes. Okay. Thank you very much, Professor Shi. My answer is I will transfer both. Of course, depending on the background of the history,
Yes.
how old she is, and how many times she unsuccessful trials. But anyway, 30% is low grade. So I think it's okay. Of course, with patient informed consent and advise prenatal diagnosis. Okay, thank you very much. Okay, next is if patient done the first PGT-A and it showed 90% of genetic chromosomal abnormality, can the patient continue for IVF and embryo freezing? Any recommends for this situation? So I like ask the participant who sent this question. Could you please give me more detailed information about 90% of chromosome abnormalities? Abnormality includes many things. It's maybe it's 90% mosaic, monosomy, mosaic, or trisomy, mosaic, whole chromosome, or segmental. But and also how old she is and how many times she experienced unsuccessful trials. But my answer is it depends on the case, but with a very many times of consultation, and this is only one remaining process, so I will transfer because it's not 100%, but usually the HRA guideline or other guideline, so cutoff of value is 80%. So over 80%, it means the aneuploidy. So in terms of that meaning, so this case should not be transferred. How do you feel, Professor Shi?
Yeah, I agree with you. 90% is quite risky, I think. And of course, it depends on which chromosomes and gain or loss, and whether the patient has another embryos, whether she have the second chance to get the oocyte retrieval, and all these things to be considered.
Okay, thank you very much. Okay, next question is, what would you consider good no process for patient to undergo PGT-A? It's a very difficult question. A number, I'm sorry. What would you consider a good number of?
I think it depends on which age the patient to, right? If
Okay.
young, she has more than 3 or 4 blastocysts, that's enough. If she's aged women, such as more than 40, then she would have 5 blastocysts to have the safe chance to get 1 euploid blastocyst.
Okay, so this means good, it means over 3 or 4, so it's worth doing PGT-A. Right? Your meaning?
A good number of blastocysts.
Okay. Okay. Our answer is good number. It means over 3 or 4 blastocysts. It's worth doing PGT-A. Okay. Let's move to the question is during Hall on day 4 compacted embryo stage recommended? Yes. Okay. I'll answer. I've read all the paper from Russia. They do the every biopsy on the Murrah stage, because the Murrah stage, it's zolapelcida and Brosomere is very far away, just a distance. So it's easier to make a hole. So, and with I forgot the special content, but special medium, make it separate the compact mollura to the isolated brasomeres. So take it brasomere 4 or 5, and the result in the same result with the 5 days in biopsy. I've read it from the Russia paper, and it was presented in the H-ray. So I think it's okay, one option. I agree. Okay, next is, would you recommend the second biopsy and second PGT-A? In the first case, the test result comes as undiagnosed, and if so, how long after thawing a blastocyst is the biopsy done? Yes, it's a very hot topic for the second biopsy. If the first biopsy result is so mosaic complex, and usually it's very difficult to transfer. But after the second biopsy, it reveals normal. So it's become common that the result from the torticollis is not consistent with a match with inner cell mass. So first and second biopsy, I think it's applicable. How do you feel, Professor Shi?
Yes, yes. If you do the PGT, all kinds of PGT, you will face the question that the patient has one embryos, which was doubtful with the inconclusive results, and you were high risky. If you transfer this embryo, I would recommend second biopsy. And we got I think at least dozens of live births after the second biopsy. So I think it's acceptable, and it's safe. Yes.
Maybe I think this paper was published an issue this year from China, I
Mhm.
think. I read it.
Mhm.
Okay, thank you.
And as long as the vitrified, the sewing blastocyst expanded, then we can do the second biopsy after the sewing. The question is how long after sewing?
Oh, so I'm sorry. Honestly, I haven't done the second biopsy.
Mhm.
So have you ever done?
It depends on the blastocyst development. If the thawed blastocyst re-expanded again, then we can do the second biopsy.
But it takes 2 or 3 weeks until the results come back. So
Yeah, several hours.
7 hours. Oh, in house. You're doing in house.
Yes, we
Oh, it's
hours
good.
sewing blastocyst re-expanded, then we can do the second biopsy.
Oh, it's good. In Japan, uh, generally, it's not allowed to do another NGS in house. We have to ask the reference laboratory, all of them. Okay. Oh, it's close. It's approaching the end of the time. But one more question. Boss doctor, I think it's very important to set priorities in mosaic embryos depending on the mosaic rate to increase the pregnancy rate. But it is waste not to transfer them if there is a high grade mosaic pregnancy rate. How do you feel about it? My opinion? It's very tough, tough question. How do you feel, Professor Shi?
We cannot count on the mosaic rate to
Mm,
the fate of the mosaic embryos. The evidence is not enough to support the mosaic rate to be the criteria to decide the blastocyst fate.
okay.
So
Okay. Thank you very much. Maybe this is the last question to Professor Shi. Do you think nuclear transfer, you mentioned about it in your slide, is effective to save age oocytes? Nuclear transfer is developed by John John.
yeah,
You know him?
by experimental, I think so.
He developed this technique, and he is the first reporter in the world.
Hmm.
So nuclear transfer, it was admitted in the UK country, but it's limited to the mitochondrial diseases. But John John applied his technique to save the aged people. It was, and it is reported in the SLM maybe 2 or 3 years ago. He's my very close friend, and I'm very interested in this nuclear transfer. So that I would like to ask you. But okay, thank you very much. Okay, so Professor Shi, could you give one last message about PGT-A to the patients? It's the last question.
Our PGT-A is effective to some group of patients with good blastocysts, with good ovarian reserve, and of course, with high aneuploidy rate. If the patient is young and the chance of aneuploidy is lower, then PGT-A may not give her the benefit we wanted because of the consumption. But if the patient is the aged patients with very high aneuploidy rate, then the selection through the PGT-A may benefit the patient. And the purpose of our work should be minimize the consumption and maximize the benefit to the patient. Thank you all.
Thank you. Well, we have received many questions, but I'm sorry. Well, I'm afraid the time is up now. So also, we couldn't reach a definitive answer to the questions we have asked. I believe today's discussion will provide helpful information when you face troubles related to PGT-A. Finally, I'd like to thank Professor Shi, as well as all of the participants. Thank you very much.
Thank you.
Hello, my name is Dr. Ivan Sini from Jakarta, Indonesia. I am pleased to invite you to our upcoming session as part of Aspire webinar series. The topic that I will be moderating is in the field of pre-implantation genetic testing. As we know, PGT is becoming widely available in IVF practice. This has opened various positive potentials, but also potential associated issues that is warranted to be discussed. The first speaker that I am happy to introduce is Professor Junhao Yan from China, who is an excellent speaker who will deliver his lecture titled The Pitfalls of PGT-M. PGT-M is one of the applications of pre-implantation genetic testing that has given the opportunity to identify various monogenic diseases in embryos. There will be clinical, laboratory, and other aspects that we will be able to cover. Professor Yan will share his PGT-M experience in a vast Chinese population. Our second distinguished speaker is Dr. Francesca Svinella from Rome, Italy. She will talk on the hot topic of mosaicism, particularly on how we manage the expectation, criteria, and how to follow up from the European perspective. This will provide us with insights on how to counsel our patients properly. I hope we all can join the session, and we sure have an excellent discussion. See you there. Bye-bye.